Just hit record. Okay, so good morning, everybody. Thanks for joining us again this morning for our Learning Lab. Today, we're moving on from the panel cleanup assessment and into the EMR functionality. So you should have the current EMR functionality tool. I sent it out yesterday. You should also have one that's been completed as an example. And we should be ready to go. So before we get started, I just have a few housekeeping items that I wanted to mention. First off, as always, we're recording the webinar, and we'll share the recording after the session. And as usual, to keep the background noise to a minimum, please keep yourself on mute. Okay, so you should now have the links for all the Learning Labs to date. If you're missing any, please let me know or let Christina know, and one of us would be happy to forward it to you. Secondly, I know that some of you feel like there's still part of the panel cleanup tool that we didn't get to last webinar with Bruce. Unfortunately, Bruce isn't able to join us today, although he says aloha from Hawaii. So we'll look at allowing some time maybe within the next webinar towards the end of this month. I think the next one is the 27th. That being said, I think what Bruce was getting at in the last webinar was that the indicators listed for the panel management piece, those last two, aren't necessarily what every...
Are you listening on a headset on your phone?
Oh, sorry, I just had some background. Where was I? Sorry. So what Bruce was getting at in the last webinar was that the indicators listed aren't necessarily what every GP is going to want to focus on. Rather, those two indicators were placeholders, and we can change those based on the priorities within the practice. So we can definitely talk about how you would go about looking into those patients who have advanced care directives within the EMR or the self-management goals. But I think the point is that we can talk with the GP about what they would like to focus on and then think about what we might want to look for in the EMR to find that data. So one of the examples Bruce used last time was to look at how many patients who are diagnosed with COPD who are current smokers. So once these patients are identified, the GP can then work with them to support them with different smoking cessation tools. Or you could sort of look at it the other way and look at the number of patients with COPD who are non-smokers. So you just see a bit of a different, your graph over time goes at a different angle, but it's the same data. So we can talk about that more at the next one for sure if you still have some questions. Last piece is the canned reports or dashboards for the panel cleanup. And so we do have agreements now with TELUS Health, so that'll be Wolf and MedAccess, and IntraHealth to do sort of canned reports or dashboards that will help get that prevalence data out of the EMR, and we'll also look at having easy ways to make the updates as well, so it'll be more simple for the GP or the MOA to go back into the EMR and make those changes. So timelines around these have them ready, I think, in early November for IntraHealth and late November, early December, I believe, for TELUS. And we're still exploring options with the other EMR vendors. So with that, I'm going to turn it over to Ronnie and Candace from the VCH team, and they're going to go through the EMR functionality assessment. Ronnie, do you want me to move the presentation fall to you?
Is it possible for us to get presenter right?
Yep.
Thank you.
I will do that. Oh. Somebody else got it. Okay. All right. Oh. Brian, don't steal the ball. All right, Ronnie, 2 seconds.
No problem.
There we go. All right, you got it.
Can everybody see the slides there? The EMR checklist title page?
Nothing on my screen.
No.
I don't see anything.
One second. One second, sorry.
Yeah.
Yep, no worries.
Who's the host?
We are.
We are the host?
We've been shared presenter.
Are you able to see our PowerPoint now?
No. Ronnie, I'm happy to run through. I can put the slides up here and tab through them for you.
Okay, it's just that it cuts off one side of it.
That's okay.
That's fine. So the far end of the slides may be cut off. But yeah, we can do that.
Okay. All right, I'm taking presenter right back. And all right, can everybody see the slides?
Yep.
So thank you everyone for joining in this morning. Hopefully there's not too much stormy weather wherever you're at. I'm Candace, and I've got Ronnie here as well. We're both PSP BCH, and we are here to run through our EMR checklist with everyone. And there's a couple of things hopefully people have seen before, but this really ties in nicely, we think, with the patient medical home and what we've covered so far. So we've been looking at the patient panel management tool, and some of us have tested its use and are well on the way with that. This tool is a broader look at EMR functionality. So whereas the patient panel management one was really honed in on problem summaries and some very specific text fields and coded areas in the EMR, this one is really just overall the functionality, and this really just provides a structured conversation to have with a physician so that we can help to identify areas we might support for optimization within their EMR. Next slide, please. So this gives us measurable results, and when we talk about measurable, we're really just going back to meaningful use and the model that was created some time ago by our peer mentor physicians, and thought we might as well just go with that since it already exists. And the physicians, a lot of physicians know the language and have seen the model before, so we're kind of just keeping in line with that. This tool can be used to guide peer mentorship. So if we go into coaching physicians and their team and they identify that they would like some EMR support, they might not know specifically why. So this helps to identify the specific areas so that we can create a statement of work for peer mentors so that they know exactly what it is that they're going in to support. I think that it would be maybe a tool in our tool belt to support new engagement. So if we don't have a module currently running in an area to invite somebody to, we may use this as a way to engage a new physician and ask them how they're doing on their EMR and if they would like some support in that area. I think it's a nice structured approach, and that way, you know, you kind of get this routine in and go through all the topics in a nice, organized fashion. It allows the physicians to understand the EMR functionality. So you might ask them a question about a topic that maybe they haven't gotten to yet, didn't know was possible, and might want to explore had we not brought it up. So maybe it helps to understand what their EMR might be capable of. It helps to create a clear plan for optimization. So going through in this structured format helps you to place items in an order of support that makes sense, starting with more foundational things all the way up to more advanced things, and who's doing what and when, so with peer mentors, vendors, et cetera. Helps to create a plan that's clear for the clinic and hopefully clear for us. And potentially good information for divisions of family practice if our local divisions are asking us where are our physicians at in the community with their EMR use. This would help us to find trends of functionality that's widely being used or functionality that is not so much being used, and we can address that as a community and know where our physicians are at.
So I'm just going to cover next slide. Just going to cover why this tool and why are we using this now. We're now mandated to support EMR workflow and optimization. We are hearing loud and clear that physicians would like to use their EMR more efficiently. Increasing EMR use will better prepare physicians and their staff for our upcoming patient medical home. This tool can support a conversation around what functionality exists within the EMR and why they may find it useful. The use of the tool will generate specific goals and tasks for team members, vendors, peer mentors, and coordinators. So next, Candace is going to be covering the meaningful use triangle, just kind of give you a brief overview of it. Next slide. So hopefully we've all seen this, if not in depth, a little bit briefly or come across it before. This is the meaningful use model or triangle. I think this is a really good tool to bring with you if you're sitting with a physician to explain what we're talking about when we talk about levels of use. And it's really like anything. There's the foundational pieces, patient registration, scheduling, and billing that most people start with. Moving into encounter notes or chart noting, using some requisitions, starting to put medications, recalls, things like that, using it for communication such as tasks and messaging, and then moving up towards drug interactions, tracking referrals, trending medications. So the further you go up, obviously the higher the optimization or the maybe more challenging of the task. We'd like to start people, making sure that their foundation is strong, that they're putting in coded data, that they are putting in medications that are short-term or long-term so that we can go ahead and search patients by medications and we're not getting a lot of junky data, which then allows us to do all sorts of neat and advanced things in the EMR. So this is just something we thought would be a good tool to go alongside the functionality checklist and a nice visual to bring with you to physicians and clinics when you go out. Next, Ronnie's just going to introduce the checklist and a little bit about its format and what it has in the way of structure. So our checklist is called the EMR Functionality Checklist, and hopefully you've all had a chance to see this by now and have a printout in front of you to just kind of follow along with. You will notice on the far right there is a section that's cut out. It just doesn't show up on this slide here. On our slides it did, but for some reason we couldn't get it to show here. But just follow along on your paper copy. So just starting with the far left, the questions are actually numbered so that when referring to a particular question, it's easy just to mention the number when you're conveying to a colleague, MOA, or GP, or even an office manager. And then next, the categories. The categories are broad areas of functionality, and the topics get into a deeper focused area within those categories. So you can see there's patient registration, and then there's a couple of items under that
topic items under that. And then next is MU. MU stands for Meaningful Use Level, level 1 through 5, and Candace just explained on the triangle how those levels work and having the foundations and building up to 5. The Y and No is for the yeses and nos. So please place a capital Y or no in the field when you determine an answer for functionality. So it has to be a capital in order to populate correctly on the subsequent meaningful use summary. So I'm going to be going through that meaningful use summary in just a bit. As you work through the tool, additional content is there to support you in asking questions. So when you're going through the tool and the physician may say, oh, I'm not quite understanding what you mean when you say reason field, you have that additional content to support you, and you can use that to create a conversation. And then you're not seeing it on the screen here, but on your paper copy, support Y and no. So when you go back to the yeses and nos right next to the MU level, you'll see your no's, and then you go across to your support Y and no at the end, and you determine if the clinic would actually like support for those no items. So it may be that a physician isn't actually using drug interaction alerts, and they've decided for whatever reason, I don't like the idea of it, I don't want to use it, I use an app on my phone, that's not something I care for support on. You can put an N there, but for anything else that you are actually supporting them on, put yeses down that column. So that way you're still reflecting that no, the physician is not using that, and no, they do not want support for that. And then going up to the top, I'm going to speak to the legend. There, you can see there's gray for MOA, white for GP, and blue for both. So in the ideal situation, you'd be meeting with both the MOA and the GP at the same time and just working through this checklist top to bottom. But in the real world, you usually just meet with one and then the other. And so I recommend you meet with the MOA first, and have the MOA answer as many questions as she can, and then circle back to the MOA after the GP was unable to answer a few here and there. So as you can see, 1 to 5 is gray, and then 6 to 8 is blue. So you would ask the MOA the gray questions and then the blue as well. It says both because either or should be able to answer them. There may be cases where one may be able to answer and the other doesn't. So it kind of gives you an idea as to where to start. Start with the MOA, and then if she or he can't answer, go to the physician. And for the first time you actually go through a checklist with a clinic, I suggest you book for 40 minutes. That'll give you enough time to go through the topics, get familiar with the tool, work through it, and also go through some additional content because you're not going to be as familiar with the tool yet. And Candace is going to quickly run through the questions right now.
So by now this is probably looking pretty familiar to some folks out there. What we did was we took something that existed already, thanks Pito, and we simplified it somewhat. We took off a couple of questions that were really high achieving that aren't quite in the EMR yet, so we don't have to have that conversation with physicians, and hopefully made it pretty easy to use. But we're hoping that this is really just a checklist that's used in a really flexible fashion to go through the topics. You can skip questions if you know a lot about your physician and you know what they are and aren't doing with some of the questions. You can plunk in some answers ahead of time. You may know your physicians well, and this is just an update to what you might have done a couple of years ago, just to check in and see where they're at now. So it could be brand new to them, or it could be something that they're pretty familiar with because they've done something similar in the past. So because there's a lot of content in here, I'm going to whip through it unbearably fast, so I apologize. But what we did as a team, which we might suggest, We just sat at a round table, and we went around the table, and each person read out the category and topic and tried to frame it in a question, how we might ask the physician or the MOA, and why we would ask that question. And hopefully the team found some value in kind of just sitting together and going through it and really having a good conversation and hearing other people's tips and tricks or ideas or ways to encourage a physician or staff to take on a functionality that they might not have yet considered. So I'm just going to run through really quickly the questions, and if you have comments or questions about it, maybe go through on your paper list and write down some notes for yourself, and hopefully we'll have a little bit of time at the end to cover some questions. We will have some time built into the next Learning Lab as well to do some Q&A. And Ronnie and I were thinking that if anyone wanted to forward questions to us by email, we could collate them. We can put them all together and see some themes and come up with some answers or an FAQ that we could send out ahead of the next Learning Lab so that we could answer as many questions as possible, because there may be a few out there. So, starting with the patient registration, all demographics, patient status, and primary provider are very, very much linked into what we've been doing with the patient panel management. So making sure that all the patient demographics are in there, that we have patient statuses that are accurate, so active, deceased, inactive. Some physicians may have a category called casual or in hospital so that they can separate their patients that they go see in facilities versus patients that come into their office. This just allows us to run reports on the active patients and not have to cross off names if they haven't been in and whatnot. Primary provider is particularly important in group clinics where we want to search by provider. A physician wants to see their patients and of them who has this condition or those medications. So we're encouraging all providers to put their specific names in. Some clinics are listed all under clinic names, which makes searching a little bit more difficult. Day sheet type stuff, appointment types. So having types of appointments such as PAPs, physicals, procedures, helps us to prepare for the day. And if we can identify on the day sheet what types of appointments are coming in, we can prepare our rooms and look ahead. So the EMRs have these lovely colors and time blocks and things that we can use. Reason field, same kind of concept. If we use the reason field to know why patients are coming in, we can better prepare. So if a patient is coming in for results, we can see that ahead of time and make sure that the results are in the chart before the patient shows up. If not, we can get it faxed. Pull out immunizations or what have you. So moving to tasks, creating tasks in the EMR, potentially alerts as well, and having a conversation about communication. How are we communicating in the EMR? Tasks for things like today, tomorrow, next day items. Alerts for patient alerts, such as strong allergies or an outstanding specialist appointment we've been trying to notify the patient for, things like that. And how to manage tasks, how to mark them active, pending, complete, so that we are only looking at what we need to see each day. And some EMRs have a functionality for instant messaging, which is handy, although can be intrusive to the physician. So it's a good conversation to have. How are we communicating and how are we using the EMR to do that? Administration. So do we have a process for creating a new user that allows the proper access? So we don't have MOAs set up to be able to print prescriptions or write prescriptions, that each role is able to perform their functionality according to their job description. Using recalls, again, another method of communication. Recalls for future date items that we don't want to see today, but we want to see when they are due. So colonoscopies, PAPs, certain follow-ups that we might check in on a patient over 6 months or a year from now that we don't want to see that every day. but we do want to keep track of those and be able to search them and see when they're due. Some EMRs allow you to customize the screen, so colors, content, templates, windows, icons. Some of the EMRs out of the box may not be as comfortable as they could be depending on your workflow. So you can add icons to some of them, or set up your day sheet to show as well as your referrals and tasks. So a good conversation to have. Is it set up as well as it could be? Moving on to the medical record. Hopefully by now everybody on an EMR is doing chart notes in the EMR, but that's not necessarily the case. Problems coded. This, I think, is one of the backbones of the EMR, ensuring that we have coded problems on the problem summary or disease registry or in history. Each EMR obviously has its own language, but making sure that there are coded conditions so that we can easily pull up lists of patients or registries of our chronic patients, CDM patients, mental health patients, things like that. So along with that, we can code allergies, history, medications, measures, immunizations, so just whipping through those. You know, obviously there's value in some of these things being coded so that we can search them or graph them, or that they pull into templates, that they print on referral letters. Some good reasons for entering coded data. It does more than just putting something in a text box. It does a lot of other things. Some of the EMRs can create really comprehensive care plans. So a care plan might be a flow sheet or a set of guideline care with recalls, or a checklist of things that we would want to do throughout the year to manage a specific condition. Some of them come with care plans, and some of them can be created. We can also talk with the physicians and teams about what's available on their EMR websites to download into their system, because they may not have very many of these kinds of things yet. We want to know that physicians are able to review their results and sign them off, task them, etc. And lab ordering. So we might still have quite a few physicians that are not actually ordering labs within their EMRs for various reasons. One that I hear a lot is because the requisitions from Life Labs is free. It doesn't take toner and paper. So having a conversation about the benefits of actually doing it in the EMR, that you can reprint it, that it can reconcile, that you don't have to type it into your encounter note because it'll already populate it. It's got a lot of benefits for ordering labs within the EMR. One way that we can encourage people to order labs in the EMR is to create lab order sets. So sets of commonly used exams or lab recs. So as an example, for menopause or diabetes, there may be a certain set of labs that we order every time. If we create the set, then we are choosing one thing instead of 6 things or 7 things, which should streamline the workflow for the physician and make ordering quite simple. It's also, even though we talk about most commonly used sets, it's actually really great for the really uncommon sets, because they may not remember just exactly what they should be ordering for a more rare condition that they don't see as often. And if they create that set, then they don't have to remember those ones that are not so common. So then we move to ordering imaging. Are the physicians using their EMR to order x-rays, CTs, ultrasounds, things like that, which leads to potentially auto-populating requisitions, so ones that auto-populate certain charts or features, demographics, their name and MSP number, things like that. So there are a lot of templates, and it's usually, even for physicians who have been on EMR for quite some time, templates is always a good area for support, because there might be community-specific ones like Grieg and Associates X-ray, whereas you know, North Vancouver wouldn't use that, Vancouver would. North Shore Imaging would be a North Shore thing, whereas Richmond wouldn't use that. So have these been created? Are they online on the website? And if so, then we could download them. Odds are somebody's already paid to have it made. We just need to have them imported into the EMR. New prescriptions. So next page. And again, I apologize that there's so much text on the screen. We're just hoping that you're not actually needing to read along on the screen, that you've just got something in hand you can follow along with and write some notes on. New prescriptions. So entering prescriptions in the EMR rather than still using the prescription pad, which we still see a lot of, especially for titrated prescriptions or prescriptions they couldn't find in the formulary, or just because they're really quick physicians and entering prescriptions slows them down. A good question is about how they handle renewal requests from the pharmacy. Are they handwriting it? Are they just signing the renewal, faxing it back, and are they actually putting it into the chart? Are they updating the medication in the patient's record? Are they scanning the signed request into documents where we won't necessarily see it? So there's probably a better way to do it. In prescriptions, you can have a list of favorites. So if you commonly use a specific antibiotic with a specific dose and length of time for strep throat, you may want to add that to your favorites so that you don't have to add all those details every time. You can select it. And ad hoc, do they understand how they could easily ad hoc a medication that might be new or not in the formulary yet? We depend on the formularies that come from other sources. So, you know, can they easily bypass the formulary and potentially create something like a compound cream, which is selecting two different types of cream? You know, they could ad hoc that. They can add it to their list of favorites as well so they can save it. And drug interaction alerts. So I find what I come across a lot of times, the drug interaction alerts were so annoying they've turned them off, but they can be customized by severity. So what drug interaction alerts are is if you enter a coded allergy or they have another prescription on file and you go to prescribe something, if there is an interaction, an alert will pop up and say, are you sure you want to prescribe this? And it's a nice catch-all if you're entering your prescriptions and allergies in a coded fashion. You know that there may be a caution there. So creating new referrals. There's still quite a few folks out there that are handwriting referrals, especially if you talk to specialists. They will let you know just how many they're getting still that are handwritten and not produced in the EMR. So walking people through what it might look like to do referrals within the EMR and what could auto-populate onto their form so that they don't have to type it all out. Asking the staff if they have a way to manage and track referrals. You might note going into a clinic that they have 4,200 referrals still open because they are not necessarily tracking and closing them accordingly. Transition of paper charts. There's not a lot of paper out there, but potentially for a new EMR clinic or a clinic that has an EMR, they might be accepting patients still and accepting paper charts being transferred to them. So do they have a good system of what they're putting in and where and what it's being named, which leads to naming convention. So as they're scanning results in brochures, forms, all sorts of things, are they using a really good naming convention so that their filing system doesn't become unwieldy and hard to find documents? So as a good naming convention so that you're not clicking and opening things just to find something specific. Registrations or searches. This is really speaking to putting in a lot of data. So we've got patient or physicians and staff now entering a lot of coded data, problem summaries, prescriptions, heights, weights, all that kind of thing. Can we now search by those data fields and find populations that we're wanting to specifically work with or measure. A lot of great search areas in the EMRs. They may just not have yet been viewed or have the clinic trained on how to use them yet. So, but it starts to show them. It's a really good place to show them that all this time spending putting all the data in can come back to you in really valuable ways. In view of the fact that we've not got a lot of time, I'm just going to whip through the last couple. So searches, billing might be a pretty huge subject for staff, and dealing with rejections, billing things privately so that they're not using receipt books anymore. We can then run reports, accounts receivable to see what monies are outstanding to us. Billing private and third-party law firms and forms, things like that. WCB forms is a difficult one for them. If they haven't used them yet, they could be really finicky and difficult to use. Once they're used to it, they're great, and you get more money for billing electronically. And you may not be able to submit paper ones anymore. I'm not quite sure, but they can be tricky. So I find that it's always a good area of support. And I'm just going to pass it over to Ronnie. I'm going to skip the last couple of questions. I'm going to pass it over to Ronnie to talk a little bit about the meaningful use summary and the scoring. I just wanted to note that though there's scoring on here so we can help to track progress and things like that, that we would really like to focus on the quality of the conversation that you're having with the physicians about trying to identify support. But that being said, we've got some great visual scoring here in case the physician would like to see where they're at. So, Ronnie?
So we've called our scorecard the Meaningful Use Summary. That kind of gives them a summary as to where they are in terms of meaningful use. On the top left, you'll see a bar graph, and the meaningful use levels run vertically down it, and horizontally are the percentages of where they're at. And also you'll see in the blue bars, it has the actual percent at where the physician is at. So it's kind of like a scale at the bottom and the actual percent through the blue. And then another visual of the same information is just below that in a spider chart. And the red outline kind of shows their level of use, and in between it just kind of shows what surface area in terms of meaningful use that they've covered. And it just kind of gives them a picture as to, oh, wow, all I have is that much to cover before I've completed a meaningful use 2, or whatever they're hoping to achieve. And if you look on the far side, the MU5 and 4, in most cases, physicians aren't striving for that, but they may want to. And then we have the table. So the table, I don't think it shows up on the screen well, but on your paper copy, it is all there with the totals. Running across, you have the MU levels and a total at the end. And down it, you have your score, what it's out of, and a percentage. So the what it's out of is actually the amount of numbers per meaningful use level. So in this case, in this example, MU1 has 6 questions, and out of those 6, your score shows that the physician has 6 out of 6. And then for MU2, it's out of 25 questions, and the physician has scored yes to 23 of those questions. And so it is also important to put the name of the physician at the bottom if you are actually going to be leaving this document with the physician. Because you or another PSP coordinator may be working with the clinic, and the office manager will sometimes hold on to a document like this. You don't want to be mixing those up. And then next slide. This is the EMR training plan. So as you're working through the checklist, you'll have some yeses and nos, those capital yeses and nos. And from those yeses and nos, you put the action items to work on. They're actually derived from the support yes and no column, the very last column of the EMR checklist. And then for those yeses for support, you put them on the action items to work on. So you can kind of word the actions however you like and even put in cues from your conversation with the clinic, MOA, or office manager. And then next you have training methods. So that's vendor, peer mentor, PSP coordinator, clinic staff member. That could be an MOA or a GP. So for me, I like to put in the actual MOA peer mentor's name. So when you're referring back to your training plan a month from when you've created it, you'll have that in there and you'll know exactly who to follow up with. And also if you're actioning an item to a staff member, like an office manager or an MOA, it would also be nice to have their name in there so you know exactly who to be calling to ask for and also refer back to. And next to that, you'll see the completion date goal. So the clinic should be able to come up with this on their own. This isn't something you decide. You may not know what they have planned for their clinic. They may be doing a version upgrade on their EMR, so they may want to wait a month or so to actually work on an action item. There may be things they can do right now, or they want to do 3 months from now. It's up to them. You want to be realistic. You don't want to set them up for failure. And date completed is the actual day that they completed the item or that you hear that they've completed the item. And sometimes they'll be excited and be like, oh, we had our peer mentor training on such and such a date, and we have now implemented items 1, 2, 3, 4, and 5, whatever it may be. So you put the date in as you go along. And status. For status, it's complete, in progress, deferred, and not started. So as you're working with a clinic, you want to be populating a status so you can kind of use this as a working document. And that way you're not going back to the clinic and asking them about things that they've already completed. Or you just kind of have a place to kind of start your conversation. And progress notes. So progress notes, you really just put in whatever you feel is important when working alongside the clinic. It could be something that's not working for the clinic in regards to that action item or an EMR glitch. Anything you feel is valid or something that the clinic would want to remember. And then also, once you've completed this and you've got most of it complete or whatever you think will actually be completed, and you don't think the clinic is going to go any further with this, you go back to your checklist and you update your capital Y's and N's in that column right next to the MU level. So you update that and change your no's to yeses if appropriate. So that will then repopulate that scorecard, that meaningful use summary, and you'll have different percentages and numbers for your MU level in each of the categories. And so now Candace is just going to go over our next steps going into the next Learning Lab.
So the next Learning Lab is October 27th, I believe, and we'll share with Bruce if he's able to come on as well, but really just do some Q&A. There's a lot of content here, and I apologize if you've already nodded off. But hopefully you may get together as a team or ask some folks who've done some EMR support for some tips and tricks to certain questions that might be unclear, or how would I ask that, or why would I ask that. But as I mentioned, we'll be here to do Q&A next session, and if you'd like to, please go ahead and email us all of your questions, and we can put them together and try and answer them in a really organized fashion so that we can answer as many questions as possible. And of course, we look forward to your feedback. It hopefully just guides you to a really good conversation about EMR use and how we can support our physicians and staff to use their tool as best they can. That being said, we've got a couple minutes. Did anybody want to ask a question, a burning question, before we sign off?
Hi, it's Wendy from Interior Health. It's a really basic question, but just going back to the beginning about the, can you revisit the color coding of the MOA and GP, the gray, the white, and the blue again? I just may have missed one step in that. Seems pretty simple, but yeah, thank you.
The color coding is meant to really just identify what might be more of a staff function than a clinical physician function. So you might find that the staff are the ones who do the entering or registering of patients, demographics, and patient status and primary provider, that the physician may not even know how to update an address, versus things that are related to the more clinical side of things, like creating a prescription and adding favorites and prescriptions. That would be a physician-oriented task. So it just really gives you a little bit of a guideline as to what might be a little more staff-oriented versus a little more clinical-oriented. So you're not asking a doctor all about administrative tasks or vice versa. That being said, in every clinic it's different, and there may be a big crossover, or you might find that a physician does all the billing and the staff doesn't. So there's got to be some flexibility in it, but it's just hopefully a bit of a guideline. Does that answer your question?
Yes, we're on the same page. It sounds good. Thank you.
Thank you. Any other questions?
Hi, Candice. Ronnie, this is Shafali. I just wondering about the whole time frame of going through this process. You mentioned earlier that you would meet with the physician and MOA for 40 minutes to begin with. So if you can just maybe outline that, that would be really helpful.
Typically, if you're lucky enough to get them both in the same room at the same time, and you can whip through the questions, I tend to just put a lot of notes in the comments area or scribble all over it if I've brought it in paper format, and take it back to the office and formulate a plan and let them know that we'll get back together again and we'll go over what the plan looks like and get some agreement on that. But it's just hopefully a really good conversation that takes half an hour to 45 minutes to get through, unless you know the physician or the staff well enough to be able to answer some of the questions.
And also the training plan is something you take back. So you take your yeses and nos and bring them back to the office and work on the training plan in the office with support from your team members that may be able to support you on functionality and also help you with figuring out who would be best to do this training, maybe a peer mentor. It might be a coworker that you have that could possibly take that on for you, or even vendor training. So we all have staff or team members that are stronger with the EMR and can support.
Thank you.
So I just wanted to offer again, as you get a chance to actually review the document and go through, please do feel free to fire off your questions to us. We're happy to answer them. Give us a phone call. If you're about to take this to an appointment you might already have or a meeting you already have when you want to trial this, you can give us a call ahead of time and ask your questions. We're open to however you'd like to get support.
Maybe I'll ask one more question. In terms of the EMRs, is there a particular EMR that, if you haven't done this before, I haven't done this in the past, that might be an easier one to start off with, to just in terms of my own confidence and just developing this skill?
I think for the most part, the most commonly used EMRs can do most everything on here. There are a few higher level things that specific EMRs might not be able to do, but as far as at least up until meaningful use level 3, all the EMRs are capable of doing 99% of what's on the checklist. So, yeah. So, and I know some of our areas are predominant in one EMR or the other. So, I would really encourage you to find a physician that you know well or you have a relationship with, and ask them if you can trial this and go through it, so that you can work with someone who you're comfortable with before you go out and engage a brand new physician. You know, we've usually got 1 or 2 physicians that will allow us to trial new things or experience these things with that we're comfortable with. So I'd recommend thinking about who you might want to go out and try this with.
And also, for an example of topic items, you may want to mention the GPSC incentive fees. That's one of the hooks of getting a physician to do the checklist. If they hear that they can get support around that, how to pull reports on that. And the other thing is WCB billing. A lot of physicians would love the support for their staff on that.
Joan here, I have a question. How long do you think this would take in the field if it being administered by a PSP team member with very minimal familiarity with the EMR and no access to a colleague expert?
That's a good question, Joan. We are going to have on the next learning session, I should have mentioned, we're going to have one of our VCH PSP colleagues talk about her experience. She's done a couple of these checklists, and she doesn't have an EMR background. And she's going to let us know how it went for her and her tips and tricks for those who aren't as experienced with EMR. Hopefully, because you don't need to know how to do everything in the EMR, you're not sitting there training them on the functionality. It's really just more of a prep for yourself to know what the possibilities are. So we know that we can do recalls, and we know that we can have these reports or registries pulled by certain pieces of data. We don't have to know exactly how to do it in each EMR. So to really just gain the confidence in the topics themselves and not how to actually do it in the EMR, we can pull in peer mentors. We can then come back to the office and ask team members or other health authority team members, other physicians or staff that you're close with, if you need to learn a little bit more about it. And, of course, you can always recommend vendor training should we not have a specific peer mentor for that EMR in the area. There's always vendor training to fall back on. So
good points. I don't know if you have had a chance yet to look at the comments section of the on-screen chat because you were presenting. One of the things that I think would really help this tool to be more easily used by team members who have neither EMR skills nor medical practice workflow experience would be to augment this tool with a context tool or a document that gives some context for each one of these questions, because the suggestion for everyone to get together for you know, how you would frame this or how you would ask it, I think is a great one. And I also think that many folks that I work with would increase their confidence if they could also refer to an additional document that talked about number 3, patient registration primary provider, you know, and so that if they were confused or if the participant asks multiple questions that we can't answer, it would be so helpful to have a reference document for people who are feeling a little less confident than you and your team are.
Right, and noted, And so we will take that back and we'll take a look and see what we can do. We did add additional content to review and give you a little bit of support. We may look at the content that came along with most of these topics in previous days and see if we can share that out. But I do like your feedback, and we'll see what we can do about that.
Thanks so much.
Hey, Candace. This is Cassandra. I actually work with Candace on the Vancouver team for PSP, and I just wanted to speak up because I did one of these this week, and I think, is it Joan? Was it Joan that was just speaking? Yeah, so Joan, actually, you know, these additional content things, I don't have an EMR background, but it was totally easy for me to go in and do this with a physician. So basically you just go in, so for number 3, like you said, primary provider, so you just, if they don't really know what that means, most of them should because they're using these EMRs every day. So, but if they need clarification, that's where you move into the additional content, and the things that have been bolded, those are sort of examples of what falls under primary provider or patient status. And I found it surprisingly easy to go whip through these questions really easily with the physician. So it looks a little more intimidating than it actually is when you're in the office and you're going through the questions. And most of the physicians are even, you know, inclined to show you on the EMR, oh, this is where I do that, and you're learning with them as well. And so it's actually a really cool process. And I would encourage you to just try it and then come back with feedback because it's actually surprisingly easy to use without an EMR background.
I did not pay her to say that. Thank you. I didn't know that you had gone and done one in the last couple of days, so I appreciate your feedback, Cassandra.
Yeah, of course. I just think it's important because I was one of those people that was like, I don't know if I want to try it, but actually it's really useful, and I'm kind of excited to try it again. So.
Thank you. We do have potentially something that has a little bit more content. It is a little bit wordy and whatnot, so maybe we'll see what we can add to it.
And it would just be something you would want to use to learn on your own. When you're in the clinic and you're going through these items, you really just ask the topics. Are you entering demographics? And if they look at you blankly and don't understand, or they ask you, then you go into the additional content. And most of them know what those items are. So you probably won't need all that much information. It's more for our staff to kind of help you along and guide you through it. And if you do have a little too much content, it can get a little wordy, and you may lose the actual topic in trying to explain it all together. And it just takes way too long to go into.
We're at time, so good questions, and hopefully there's more questions to come if you need some clarity, and we can help out. So again, email us the questions, or we can address them October 27th. Thank you.
Thank you very much, Candace and Ronnie. That was awesome. So I will send out the recording when it's ready, the slides, and contact information for Ronnie and Candace so that you guys can get in touch with them with your questions. All right. Yeah. And I think we'll call it. Thanks very much, everyone. Have a great rest of your day.
Thank you so much.